All right, let's continue with the program. So the next presentation is population pharmacokinetics and dosing simulation of meropenem in critically ill patients with high-resistant klebsiella pneumoniae environments by Dr. Anh Quan-Truong. I hope I'm pronouncing that correctly. Anh Quan is a clinical pharmacist who is currently pursuing a master's degree in epidemiology at the University of Antwerp. His primary focus is on the optimization of antibiotics and the mitigation of antimicrobial resistance, particularly in vulnerable populations such as critically ill patients, pediatrics, and elderly patients. Welcome, Quan.
Thank you very much for inviting me today to the pharmacometrics seminar. So today my presentations will focus mostly on the thinking process in model building and challenges when using non-parametric approach in building a model or population pharmacokinetics model for meropenem in ICU patients, and with a focus on highly resistant klebsiella pneumoniae environments. And why is that? So if you can see here on the right right figures, Vietnam is one of the countries that are standing out in the resident rate of klebsiella to carbapenem. And also on the left-hand side figures, you can see like this is our local MIC distributions, and like more than 50% of the isolations is resistant to meropenem, which is really alarming. So bearing that in mind, we decided to conduct a small post-PK study in meropenem in ICU patients in order to build a post-PK model. And from that model, we perform the simulations to access the PKP target attainment against our local MIC distributions of klebsiella pneumoniae. And in order to do so, I will walk you through our from the beginning to the end of model building and when we published some challenges. So first of all, we conducted a sparse sampling strategies, and which was embedded in our clinical settings, because we think that our ICU is kind of like busy and things happen quickly in the ICUs. And we think that is like, we also want to see the feasibility of sparse sampling strategy also. And the sampling period went quite well because we received the good acceptance and support from the ICU leaders and the ICU units as a whole. So for each patients, we collect a set of PK samples, including 2 plasma samples at steady state, which is at least 3 doses of meropenem. And if you can, as you can see on the plot right here, the first samples were collected half an hour after the finish of the infusions of meropenem, and the second samples were collected 1 or 2 hours prior to the next dose. Depend on the dosing interval is 6 or 8 hours. And during the study dose of meropenem, we also collect a 8-hour urine sample in order to more accurately estimate the renal functions. And the patient we included in our study is 8 patients admitted to ICU without pregnancy or lactations and without receiving any invasive procedures like ECMO or renal replacement therapy or plasma exchange. And for the microbiology data, klebsiella pneumoniae MIC distributions, we archive from our hospital microbiology laboratory. And for the modeling strategy, we chose non-parametric method with a workflow similar to the general workflow from the structural model building to covariance selections and to model diagnosis. And why we chose non-parametrics? Because we think that with a small sample size that we got and with the sparse sampling strategies, the assumptions on the distributions cannot be met in the nonlinear mixed effect model built by parametrics. So we want kind of to relax that assumptions, and therefore we offer non-parametric. And we also want to see whether we had or didn't have any subpopulations in our sample, because our ICU is a mixed medicine ICU. So we think that it's also worth to look at. And for structural model, we go from the 1 compartments with error model like additive or multiplicative. And one remark here that I want to highlight is in p-matrix, we chose p-matrix to conduct the model building. And in p-matrix, we need to set a parameter bound for each population parameters. And this bound is kind of sensitive. because if we set an inappropriate bounds, it can lead to bias estimate or even overfitting the model into two compartments model, which is not really reasonable for our small samples with sparse samplings. So this is kind of an iterative process when we fit and refit the structural model to find the best parameter bound. And of course, we also need to based on the previous study also and the rationale behind that. And after we got a structural model, we come to the covariate selections. We look at different relationship between the covariates with the PK parameters, and we also used like the stepwise approach with forward and backward selections to avoid the overfitting of the covariate in the models. And lastly, to diagnose the model fitting, we use visual graph line predictor fits or VPC as usual. And we also look at the bias in implicit values, and we also perform the bootstrap to obtain the uncertainty or the 95% confidence interval. And one remark here that I want to highlight is we knew that we have a high variability in our samples. Sorry, and some parameters are really like have a high variability, so their lower bound of 95% confidence interval can be a negative values, and which doesn't make sense. So we set the lower bound at 0 to avoid that. And after we have the final model, we perform the Monte Carlo simulations in IP metrics, and we estimate the probability of target attainment, which is a generalized approach with the two targets with 40% of FT above MIC and 100% of FT above MIC with two infusion strategies, which is a standard and continuous infusions. And we also want to look at the cumulative fraction of response, which is the integrations of the local MIC of klebsiella here, as you can see the figures, and the probability of target attainment also. Although this value cannot be generalizable to other settings, but it reflects our local situations, and we also want to see what is the probability of target attainment in this MIC, in the extreme MIC distribution like this one. So we also chose to estimate these values, the CFR, and we also perform on two targets, 40% and 100% of FT above MIC. And we also know that with this guy, with the really high and extreme MIC distributions of klebsiella in our populations, we knew that if we perform the simulations in order to get a target attainment, we need to use the dose that higher than standardized dose. So we think that we need to set a threshold, a toxicity threshold, which is a nephrotoxicity for two mode infusions. So for the extended infusions, we chose C-mean, the minimum concentrations at 44.5 milligram per liters. And for the continuous infusions, we chose the steady state concentrations at 100 milligram per liters. So that is a briefly overview of the method that we chose and why we chose. And now I will briefly walk you through the results, some challenges, some remarks from the reviewers that we received when we submit our manuscript. So first of all, the sampling scheme, and we know that from in advance that they will worry about the sampling scheme that we chose, and actually they give a long comment about that. Like with the first sample collection, with the first samples, they commented that the first sample there were a lot of single information in the volume, and for the second samples, they commented that it was taken far too early from the optimal time. And we argue that because we embedded our sampling strategies into our clinical settings, so we anticipated some variability due to the clinical conditions when patients are transferred to other units to perform the examinations. We collect the sample earlier than expected, and it can show here on the graph, but we knew that we need to record the time, the exact infusion time and sampling time, which is the key for any PK studies. So we think that if we recorded the time exactly, you can still modeling it. And for the second samples, we indeed took early, but we try to avoid the concentrations below the lower limit of quantifications by our assay. And in order to to prove that our result is credible, we also perform the robustness analysis by refitting our data to our available models. And if we got the same result with our model from other models, so it is credible. And for the final model diagnosis, so in the left-hand side figures, the fitness of our model is quite good for populations and individual. And on the right-hand side is a visual predictive check. So if you can see, like on the right part of the VPC plot, the figures show like uncertainty in the model predictions in low concentrations, which is also our limitations when we took the second sample is a little bit too early. And 80% of our observations is lie within the 50 and the 95% similar percentiles, which is kind of acceptable when our observations is kind of evenly distributed around the 50 percentile of the simulations. And to like to assure the robustness of our non-parametric model, the result from our non-parametric model to the reviewers, we refitted our data to the available parametric models and Y-parametric, because we think that is a good reflection between non-parametric and parametric method. Because this method is kind of two sides of a coin, and it's good to look at both. And furthermore, we cannot access to the distributions of the non-parametric model, which is essential for like simulations or refitting the data to the published model. So we opt for the parametric, and we perform this refitting the data by meropenem with a maximum of posteriori estimations by adjacents. And the tables here that we show on the slides, also a table that we respond to the reviewers. And on the first rows, it is the impact model or the non-parametric model in our studies. And you can see that compared to one compartment and to some of two compartments model published already, the mean values of our clearance is somewhat similar, around 9 to 9.5 liter per hour. And for the mean of the volume distributions, is like similar to other one compartment model, and so similar to the sum of two volumes of distributions for the two compartments model. So from our sparse sampling, and when we refit with the published parametric models, which is usually favorable more a little bit in our pharmacometricians world, and we still saw like the similarity in the result that we obtain from two methods. So we can justify our results, our method, and our like model building process to the reviewers. And the final result is kind of fruitful for us. The reviewers gave us a good comment. They have done a good job at responding to most things, including defend and justify for our models. And from the models, we also we were able to come up with like dosing scheme or dosing recommendations for ICUs. We did come back to the aim of our study is to optimize the dose of meropenem in our like extreme MSC distributions of klebsiella pneumoniae. And our study, our work were published in AAC with our colleague from University of Queensland also. So to conclude on my presentations, I want to highlight some lessons learned during our model building process from scratch. It's a challenging but also interesting process. And from this model building for meropenem, I learned that it's always good to have reflections between non-parametric and parametric modelings, and they should come together as a whole, actually. And in resources limited settings like Vietnam or other developing countries, a sparse sampling can be feasible, but we need to take a step thoughtfully and reasonably to be able to justify for our choice. And lastly, we also received like a very critical comments from the reviewers, but that like significantly improve our model also. So there will be always some concerns about the model that we build, but we think that is not necessarily be the best, but the model at least be the most fitted with our situations, or at least with our data and with the sound arguments also. And to conclude on my thought, I want to put the quote that really famous in the pharmacometrics or any modern word is, essentially all models are wrong, but some models are useful. So thank you very much for your listening. I also want to give my thanks to all of my colleagues in my centers, my universities, in my hospital also, for the professors from University of Queensland. Thank you very much.
Thank you for your presentation, and that was very insightful. I wonder if anyone from the public has any questions.
Quan, excellent presentation. It's Oz here. I've got a question for you for one of the reviewers for that paper that we published, where they asked the question, your targets that you set at 40% and 100% time above MIC, especially for things like extended infusion and continuous infusions that you simulated. What justification can you provide us for using those some would argue lower exposure targets?
Yeah, thank you very much for questions. And I think we also received the reviewers' comments on our papers. And that's why we chose to perform to target, because the 40% of 40% the target of 40% of the time above the MICs is more suitable for the extended infusions, and it's not really suitable for like continuous infusion also, because due to the natures of the PK profile in the extended infusions, when we have peak and we have the trough concentrations, and that can somehow lead to like a higher PTI or higher probability of target attainment when we apply the lower target for this kind of infusion mode, but the extended infusions is not really suitable to meet the target at 100% of the FT about MIC. So therefore, but it's the case for the continuous infusions when the PK profile is just a stable line, and we can if we can somehow increase a dose at a certain level, we can somehow can meet the unhurt target 100% of FT above MIC for the continuous infusions. So that's why we chose two separate target actually.
So thank you, nice presentation. So I think this study was conducted in a setting of high drug resistance, as you mentioned. And the previous in vitro studies, especially in hollow fiber infection model, they have demonstrated that continuous infusion is less likely to suppress emergence of resistance compared to intermittent regimens. So how confident are you in recommending target attainment for a continuous infusion in higher resistance situations that you're facing?
Yeah, so we also look at that also aspect when reviewing our studies, and actually we think that from the established animal models that the resistance, in order to suppress the resistance, in order to reach the target at least 4 or 5 times, the Cmin at least 4 or 5 times above the MIC. And however, if we apply that kind of target in the clinical settings or in the model, it's somewhat cannot be reached due to the really high MIC in our settings also, and due to that is that cannot really be feasible in the high resistance settings. So with our studies, with our dosing recommendations, we know that a small proportions of resistant pathogens can at least meet 100% of target attainment, but we cannot show that we can suppress the resistance also. And actually, we are also not confident when apply the intermittent infusions to suppress the resistance, because the target attainment is just we just set at 40% of the time above MIC. So we are not really sure. And in the high resistance like ICU in Vietnam, we also need to combine the antimicrobials with the meropenem also. And our study just look at the meropenem. So, but actually we need to combine the antimicrobial when we come to clinical settings.
Thanks. And there were some comments that you made that I really liked during your presentation. One of them, the importance of the sampling scheme. I think people usually think we do magic and that with one sample we can just get the whole PK of a drug, and that's often not the case. And the other one being using the actual data We often get data sets with nominal times, and that brings a lot of error. And we always reach back to ask for actual times and exact times. And so thank you very much for your presentation. Thank you for making the time to be here with us.
Thank you very much.